Welcome to the first part of our lung ultrasound series. My name is Jared Saleme. I'll be narrating the following slides. So in this lecture, we'll be discussing what a normal lung ultrasound looks like, how the air fluid physiology affects the image obtained, and we will be discussing the three major profiles in lung ultrasound, the A, B, and C profile. The main structures we'll be looking at throughout this lecture will be the lung parenchyma, pleura, and costophrenic angles. So to best visualize a lung parenchyma and pleural effusions, low-frequency probes are preferred as they can penetrate deeper into the chest wall and chest cavity, whereas high-frequency probes, because of the better resolution they offer, are excellent for pleural imaging. Lung ultrasound is a relatively new imaging modality and has only gained momentum in the last 10 years. It used to be difficult to interpret any images as air would lead to the refraction of most of the ultrasound beams and therefore making the images beyond uninterpretable. However, when we are evaluating lung ultrasonography, we aren't so much looking at images but actual artifacts created by the underlying structures. A lot of the structures we see on lung ultrasound are actually artifacts, and the artifacts are created by what's known as an acoustic impedance mismatch. On the bottom right of the screen, we see two tissue samples, tissue 1 and tissue 2, of different echogenicity. This difference in echogenicity is known as the acoustic impedance mismatch, and it dictates the amount of ultrasound beams transmitted versus the amount of ultrasound beams that get reflected. And knowing that, for example, air completely refracts ultrasound beams, whereas fluid and solid structures allow its transmission, we can start seeing the development of these artifacts based on the amount of air to fluid ratio. This graph illustrates very clearly the relationship between air-fluid ratio and the kind of artifact being formed. On the y-axis, we note the percentage of air within the lung, while on the x-axis, we see the percentage of fluid within the lung. Normal lung is around 99% air, and the only time where it is 100% air is if there is a pneumothorax where air surrounds the lung. And in both cases, they form what are known as A-lines, which are basically the absolute refraction of the ultrasound beams once they hit air. Moving on to increasing the percentage of fluid within the lung, we then are faced with the interstitial syndrome, and in this case, there's a very different artifact that's being formed, known as B-lines, and as the percentage of fluid continues to increase, these B-lines tend to form lung rockets. Finally, as we go down further, where the amount of air now precipitously has dropped and the percentage of fluid continues to increase, this is a setting in which pneumonia can look like a consolidation, as more solid structures allow the transmission of the ultrasound beams. Again, we see this as there is more and more consolidation being formed. In other words, there's more and more fluid within the lung and less air. And finally, until we get down to where there is absolutely no air, and in fact the lung is now surrounded by a pleural effusion. This slide emphasizes the air-fluid ratio and its importance in the creation of different lung artifacts. On the left side of the slide, we see that with high percentage of air, we have a very specific artifact that's being formed again. Here, if we begin with the diagrams on the top, the first rectangle represents the parietal pleura, while the rectangle represents the visceral pleura, and the structures underneath that are the septations within the lung that are filled with air. As we see here, as the ultrasound beam represented by the red arrow hits the parietal and visceral pleura, because of impedance mismatch, some of it gets transmitted back up to the ultrasound beam and therefore creates the lung artifact known as the A-line. A very different physiology for ultrasound beam transmission occurs as there is more and more fluid within the lung. For example, when the air-fluid ratio is around 95%, the ultrasound beams actually do not get refracted so much as they get transmitted across the interlobular septae that are now edematous and swollen with fluid. And this continues to happen as more and more fluid gets created until finally we reach the pleural effusion. To start, have the patient lay supine with the bed angled at around 30 degrees. Ensure that the probe markers point towards the patient's head in a rostrocaudal axis. To ensure systematic approach, it is important to identify all the lung fields, and we'll be using the BLUE protocol to do so. Another sequential approach to lung ultrasound is the use of the Volpicelli zones. There are 4 Volpicelli zones, and these can be identified and delineated by drawing imaginary lines in a rostrocaudal fashion along the sternum, then the anterior axillary line and posterior axillary line, and having an imaginary line drawn around the 5th intercostal space along those lines. Where Volpicelli zone 1 represents the upper blue point and Volpicelli zone 2 represents the lower blue point, the Volpicelli zone 4 is the Plaps point, and finally the Volpicelli zone 3 gives us another view of the posterior parts of the upper lobes. Let us begin by examining what a normal lung looks like under lung ultrasound. In this section, we'll be discussing the normal appearance of a lung in B mode, where we'll be looking at A lines and lung sliding, and in M mode, we'll be examining the seashore sign. In this image, we see what a normal lung looks like under ultrasound. It is identified by 3 echogenic lines at the top of the screen. 2 of these echogenic lines have hypoechoic regions behind it. These are known as rib shadows and occur because the ultrasound beams can no longer penetrate the bone, and therefore we cannot see beyond the tears. The 3rd line is the pleural line, and this is known as the bat sign, where the ribs are the wings of the bat and the pleura represents the body of the bat. The pleura is actually 2 different structures overlying one another, the visceral and parietal pleura. And there's such a degree of impedance mismatch between the visceral and parietal pleura and the underlying air-filled septae of the lung that some of these ultrasound beams get bounced back to the machine, and therefore we create the reverberation artifacts known as the A-lines. What is interesting is this happens sequentially, and the distance between the pleural line and skin is the same distance between the pleura and the first A-line, and this happens over and over again. This image illustrates how symmetric A-lines can be. In fact, the more perpendicular we are to the pleural line, the more echogenic A-lines become, and the more of them we tend to see. A-lines represent air either within the lung or outside of the lung. Therefore, they can be found in normal lung tissue or in the setting of a pneumothorax or COPD where there's a large bleb within the lung. What is interesting with A-lines is that they are the first to disappear in almost any pathology except the ones that we mentioned just previously. We recommend beginning with pleural assessment anytime we are doing a lung ultrasound. We can use a low-frequency probe to look for the pleural line. However, it is best seen with high-frequency probes, as this allows for greater resolution. When assessing the pleural line, it is important to look for the degree of sliding that's occurring, if the pleural line is regular, and to look at the thickness of the pleural line, although the latter is not very reliable and can be misleading. Beginning with lung sliding and or shimmering, using a high-frequency probe, we see here the clear back and forth movement of the visceral and parietal pleural layers that are overlapping one another. For this lung sliding to be present, there are 2 requirements that must be fulfilled. 1, we must have an intact visceral and parietal pleural interface, and 2, the underlying lung must be able to move. In other words, be ventilated and aerated. This explains why, in the setting of a pneumothorax, for example, the dissection of air between the visceral and parietal pleura negates the formation of the lung sliding. And as well, this can be seen in pneumonia, as a consolidation in the infiltrative process prevents the lung from being ventilated anymore, and therefore its movement is absent, and therefore lung sliding is abolished. In fact, loss of lung sliding is not very specific to any one disease. However, its absence does denote the presence of an abnormal lung. So if we do see lung sliding, it doesn't mean that we have a normal lung, but its absence tells us that something is wrong within that lung. It is important to be able to distinguish lung sliding from other pleural movements. On the left side, we note regular lung sliding. However, in a patient with a pneumothorax, we see here that there is no lung sliding that is going left to right, but instead there is tugging of the pleural line upward, This represents a patient who is dyspneic, using his intercostal muscles to try to breathe. Therefore, upward movement of the pleural line does not equate to lung sliding. Another situation that may look similar to lung sliding is the lung pulse. In this case, there is back and forth movement from left to right of the pleural line. However, as we see here, it is a very pulsatile movement, and it is very brisk, and it corresponds to the patient's heart rate. The lung pulse is actually created by the transmission of cardiac impulses across the chest wall all the way to the pleural line. This will be further discussed in later chapters. The next step in evaluating the pleural line is whether it is a straight line or an irregular one. On the left-hand side, we see normal lung sliding in a healthy lung, and on the right side, we notice that the pleural line, instead of being straight, is rather irregular. This irregularity occurs in the setting of resorptive atelectasis that happens secondary to consolidations infiltrating into the lung and leading to this resorptive atelectasis and therefore pulling down on the pleural line. By understanding what a normal lung ultrasound looks like, we may be able to identify pathology very early on in our assessment. For example, the loss of A-lines or lung sliding is never normal, and therefore immediately indicates underlying pathology, although remember, their absence is nonspecific for a single pathology. Be careful, however, that the presence of A-lines does not necessarily mean only a normal lung, but can also be seen in pneumothorax, COPD, or asthma. And the same applies for lung sliding. Its presence does not mean that all is well.